Okay. Questions.
We
I
have
love
some questions from the online audience.
Yes.
Lori and Kathy are asking if you have suggestions for chronic fatigue syndrome, any books, studies, or how to integrate that here.
Okay. Yes. I don't have books studied. Again, everybody asks for books. So chronic fatigue syndrome is it's a syndrome, and what we want to do is realize that we want to do similar things that we're doing with chronic pain. It's a syndrome state, and we want to work on the activation. We also have neuroplasticity changes. We want to follow the same model of care. Okay, we may not jump right into the same pain protocol right away, but we want to look at the neuroplastic issues at hand. We also want to look at the chronic activation of the sympathetic nervous system, work with self-soothing, and constantly be assessing the nervous system states, monitoring, and settling that down. Also, polyvagal, looking at where is the co-regulation in the person's life? Where are they connected? Again, co-regulation isn't just about in this moment. It's where am I in a place in my life where I feel connected and safe and secure, and where I naturally am in that monkey brain, into that ventral vagal system, and build on those. And try to get people in those, because that chronic fatigue is also a chronic collapse often. And so it's a lot of the biochemistry with chronic fatigue that we want to work on, activating GABA and those good neurotransmitters. And it's also chronic inflammation. So we want to look at the same kind of program, model of care. And also, and I don't say that we don't use the pain protocol, but we use it with modifications some. For instance, when you feel the fatigue or you feel the pain, that dysphoric pain that you have, what is it? Can you describe it? What does it look like? What does it feel like? What sound does it make? I didn't teach the pain protocol, so I don't want to get into too much of the specifics of that. But it's the same syndrome state, so we don't want to look at it as a completely different situation. I hope that made sense.
Thank you. We have some more, but we can alternate with people asking at the mic.
Sounds great.
Hi. I'm Heidi Pidcoke, and I just want to say thank you so much. It was an amazing presentation. I'm a somatic psychotherapist.
Thank you. Thank you.
I'm a somatic psychotherapist as well as an EMDRIA therapist. And one of the clients that I'm working with who has very inconsistent pain, the question that I have is about the consistency about always using soothing technique. Because what we heard earlier with Gabor Mate was about this personality trait which represses anger and represses the part that is able to stand up and advocate for themselves. And so sometimes with this certain client that I'm thinking of, I'll have her just say no and and use her hands and just say no. And when I ask her to check into her pain, after she's able to say no, just no to anything, her pain goes away completely for a short time. And so sometimes I'm just curious about your thinking that it's not because I'm not soothing her at that moment. I often do soothe her, but in those moments I want to activate her capacity to come out of the collapse.
Right. Okay. Context. Okay. Context is everything. That's a great question. Now, depending on what state I'm in, right? Okay, if I'm collapsed, I need to mobilize, right? So if I'm in a collapse state, I need to mobilize, but I don't need to stay in mobilization. I need to move through mobilization and get up to a ventral vagal system. Because if I'm in here, if I'm in activation, that's not, staying there is also no good. That's no bueno. Okay, we've got to move through that into co-regulation. Now, and it depends on what I'm doing right now. If I'm working on with somebody and their trauma, and they were, and they needed to protect themselves, okay, then of course, in that moment, I'm not going to say, soothe yourself right now, right? Okay, so when I'm talking about self-soothing, I'm talking about if we're in chronic activation states outside of sessions. That's where I'm talking about soothing, okay? Okay, now if I'm collapsed at home, soothing, you can't soothe when you're collapsed, right? Okay, because you don't have any resources going to your brain, your body's in hypoactivation, you're curled up, you're not doing anything, so what you want to be able to do, soothing isn't necessarily mean inactivity, okay? Soothing is taking care of yourself. Okay, so soothing might be, getting up and going for a walk or going with a friend. Okay, co-regulatory, soothing is wonderful. Go be with a friend and, go to a movie. Okay, things like that could be very soothing. I love co-regulatory soothing. When I do couples work, a lot of my, work is, soothing with each other, co-regulatory focused soothing. Okay, so I don't want to get the impression that soothing is always, just, coming down. Because sometimes if you're collapsed, soothing needs to be coming up through this to here. Okay? Sure. Yes, ma'am. Oh, wait, I'm sorry. I alternating between the...
Yes, just a quick one. Barbara has a question. Do you have a simple explanation about the physiology of chronic pain that we can share with clients with different educational levels?
Yes. That chronic pain isn't the same as acute pain, that it changes your whole body, your whole nervous system, and the way your whole body is working. And what we want to do is bring you back to an acute pain functioning brain and body, and that it's a step-by-step process that has to look at the whole you and not just pieces of you.
Ready?
Yes.
Okay, if I understood correctly, you said that with neurotech, to get 1 beat per second, you said it at a 5.
Well, just under 5.
And I'm wondering how you would ever get 1 beat per 2 seconds, then. It wouldn't go low enough.
Just under 4.
Oh, really? And
Yeah.
just under 3 is 1 beat
About every 3
3
seconds.
seconds? Oh, wonderful. Thank you.
Sure. Glad I could help. That was easy.
Next question from the online audience.
Yes.
How do you handle situations in which your client seems to want to hold on to the pain? They like the victim role.
I address it with them. I talk about it in a very kind, again, the 4 A's of attachment. Okay? Attention, attunement, affection, and appreciation. But we have to talk about that. And I would very kindly say, gosh, what would it be like if you didn't have pain? I explore it with kindness and curiosity. And I have them, they'll usually say, well, life would be great. And I say, okay, well, explain that. I have them use their mind and their imagination to really look at that. And then I'll ask questions. Well, what about this? What about that? And then usually we'll get to, and with that, we'll find out what is their, their barriers or relationship, and through asking those questions, well, what would your relationship with your children be like? What would your relationship with your husband be like? What would you have to do more of? What would you, not be able to do that you can do now? What are you afraid of? And then we also, that brings it back to one more thing. That brings it back to, gosh, what about other times in your life when that was like that? Because this is where we get into, as EMDR, we want to look into, goal-blocking beliefs, feeder memories, not necessarily as we're doing EMDR, but, as we're thinking from the EMDR mind, the feeder memories, the float backs, things like that. What are all those things previously that they're not even connecting with?
Thank you.
Mm-hmm.
I think my question has to do with the intersection of trauma processing and chronic pain. Mm-hmm. The particular client I have in mind has fibro, has been dealing with it for, well over a decade, and also has some developmental small t type trauma stuff. Responds really well to all the resourcing, light stream, containment, all of that. Has a decrease in SUDS and pain. We do the trauma processing around the target memories, decreases in session. After the week after session, she's a mess. Her pain skyrockets. She's having spasms. She's feeling nauseous. She's nearly bedridden because she's just, and these are smaller T traumas. This isn't like hyperarousal, like rape combat trauma stuff. This is, you know, attachment stuff. What are your thoughts around that?
Well, first of all, I would say that the smaller T traumas can be just as
Absolutely.
powerful as the big T traumas.
Absolutely.
And so it's what I would be exploring more on what's happening in her thought process, in her life process, and what is happening in between sessions, as well as with this model too. I would be looking at, you know, she needs to be doing things in between sessions. This is very often the case, because that's why she needs to be doing work in between sessions to you know, help with this rehabilitation, reconditioning, rehabituation. She's probably perseverating and ruminating on things that she's taking after session, but other things that are coming up. And I would be exploring what's coming up in between sessions, because what's happening is that you know, she's having activation, and that's causing, you know, all the stress chemicals to go awry with fibromyalgia, which is causing the increase in the fibro symptoms. Okay. And so also, you know, is there a secondary, you know, gain? And again, we don't look at secondary gain as a person being, you know, quote, bad. It's what's happening. You know, if she gets better, what is she worried about? And that there's, you know, more work to be done to uncover that. Okay, but that's very common. But she might be ruminating about something, or she might be going into some other, you know, areas too. So I would be exploring more to find out what's going on, and maybe doing, you know, a little bit of a, you know, maybe a daily kind of not you know,
A Tyse's log.
like a not a diary, but kind of just assessing activity, you know, cognitions, or what's going on in her life, you know, how she caretaking herself. Now with attachment trauma, there's probably a lot of lack of self-care. I'd also be looking at what's happening on that polyvagal level.
Well, this particular target was actually an encounter with a medical provider.
Huh?
This particular target is an encounter with a medical provider.
Oh, okay.
Much of what you were just referencing about how these people are treated in the medical world.
And so is she experiencing that, or perceiving she's experiencing that in other areas of her life?
That would be a good question. Thank you. I appreciate that.
You're welcome. Let me go over to this side. I'm sorry, I didn't mean to ignore you over there.
No, thank you.
And then I'll get somebody from the, after you.
My question is probably a big one, but where does the prescribing of SSRIs and SNRIs fall in all of this?
Well, SNRIs and SSRIs, you know, they're important until the nervous system is able to replenish itself. Okay, so if we're on a deficit, we have to bring it up to a therapeutic level so that they are available, especially the SNRIs. Although some SNRIs can be really hard to get off of. So, you know, I work with some other providers that we have, you know, when I refer, but oftentimes people are with providers that don't want to listen to anything I have to suggest or won't talk to me. And so we make do with what we got, you know. So, but yeah, they're beneficial. But the idea is that we have to, if we're at deficit in some things, they're necessary until we get to a place where they're no longer needed.
Great. Thank you.
You're welcome. Is there somebody from?
Yes, Catherine asked, are these recommendations and protocols applicable to clients whose pain is the result of electrocution, where there might be nervous system damage?
Well, yes, absolutely, because you have to still get those activated, damaged nerves to turn off. Now, but to keep in mind, if there's nerve injury, that nerves take a long time to heal, and I don't know, I can't answer the specifics too much without knowing that specific case. But nerves, if they're damaged and healing, they take an awfully long time to heal, but it's still applicable because we want to create an environment of healing for those nerves. Otherwise, we can get some really nasty issues with nerves that don't heal well. And so, yes, it's very applicable to that, especially getting them to settle down rather than be activated.
Hi. My question is related to medications that have been given. Like, I have clients that have been put on GABA, and if that's stopping the brain from feeling the need or the body to be producing GABA, is that a possibility? Just like taking antibiotics and having
Like
the
GABA
immune system?
supplements?
Yeah, yeah.
Yeah, I really can't, I'm not really, I can't really answer that as far as, I haven't read anything that taking GABA supplements prevents the body from making GABA. It just doesn't go above the blood-brain barrier, so I just know it's, through clients and through work over time, it doesn't seem to help much. I would suggest doing the GABA exercises more. They'll find way more benefit from that.
Okay, thank you.
Sure thing. Yes.
Yes, during your presentation, several times you mentioned that we stay within the window of tolerance for the SUDS, and I was wondering how in the middle of the session we know that we are within the window of tolerance.
I'm saying, I had a hard time hearing. Say it one more time.
I was wondering how we can assess whether we're within the window of tolerance during the session.
Oh, okay. Obviously, SUDS are subjective. What I usually say, let me know if you're an 8 or more.
That's,
If they're 8 or if they're higher than an 8, I'm bringing it down.
okay.
Excuse me. Yes, ma'am. Oh,
Did you have any more online people?
Is there any more from the? No? Okay. Is that a yes or a no? No, okay.
Okay, so this will be hopefully quick. I happen to work with a lot of people who are in their 60s and 70s and have chronic pain and are on opiates, SSRIs, they have a fibromyalgia diagnosis, gabapentin, and of course, and heart medications. Their doctors will not take them off of any of those things, and it's also can be dangerous to try to get them off. So I'm wondering how effective can it be, or has it been for you, to still work with people while they're on the medications or gabapentin and heart meds, doing this pain protocol?
Everything's variable. I have clients on all sorts of stuff as well. I work with people, and yeah, you still get good results. You may not get optimal results, but even if you get less, it's better than nothing, as far as results. And everybody's different, to be honest with you. If they need to be on it for health reasons, then they need to be on it. Sometimes people are on a... I'm working with a young woman right now. She's 20 years old, and she takes 50 pills a day. And it's insane, but...
Yeah, we don't know if they all have to be on everything that they're on, though, because nobody will take them off to see if it would be effective.
Right. But, this person, she just started with an integrative medicine person, and I was like, okay, well, let's do what we can do, and we'll just keep working.
Okay.
I just say keep working.
Okay, thank you.
All right, thank you. All right, well, thank you very much.